Welcome to RUMC Connections. So welcome to RUMC Connections, the podcast that brings you important conversations on health, wellness, and innovation at Richmond University Medical Center. My name is Meredith Gaskins, and I am joined today by Dr. Arthy Yoga. So thank you so much for being my guest.
Oh, you're welcome. Happy to be here.
Dr. Yoga is our new breast surgical oncologist. And October is Breast Cancer Awareness Month, which is a time that we focus on raising awareness, sharing knowledge, and supporting patients and families who have been touched by breast cancer. So today we'll be highlighting an exciting advancement in care, which is oncoplastic surgery. And as I mentioned, we're joined by Dr. Yoga. So oncoplastic surgery combines cancer removal with reconstructive techniques in the same operation, meaning patients can fight cancer without sacrificing their sense of self. So it represents a shift in how breast cancer is being treated, and it blends survival with confidence, function, and aesthetics. So in this episode, we'll discuss what oncoplastic surgery is, how it's different from traditional approaches, and what patients here at RUMC can expect when they come through the doors of our Breast and Imaging Center at 1161 Victory Blvd. So Dr. Yoga is highly trained breast surgical oncologist with a fellowship in breast oncology and board certified in surgery. She brings a unique blend of oncologic precision and aesthetic expertise to her practice, offering compassionate, comprehensive care for patients facing breast disease. Dr. Yoga earned her Bachelor of Arts in Biology from SUNY Binghamton University in 2005 and completed her medical degree at SUNY Upstate Medical University in 2009. She underwent rigorous surgical training through a general surgery internship and residency at Staten Island University Hospital, finishing in 2014. Her pursuit of excellence led her to complete a breast surgical oncology fellowship at Jackson Memorial Hospital, followed by an advanced fellowship in oncoplastic surgery at Clinique Bizet in Paris. This specialized training allows her to perform complex procedures such as nipple-sparing mastectomies and breast conservation surgeries with immediate reconstruction. Dr. Yoga is affiliated with Richmond University Medical Center. She is fluent in English and Tamil. She is dedicated to serving diverse communities with cultural sensitivity and clinical excellence. Her special interest includes high-risk patients, patients with benign breast disease, and has expertise in breast cancer treatment. So welcome once again. Thank you for joining me. Let's start with understanding the basics. So can you please explain in simple terms what oncoplastic surgery means?
Sure. So oncologic surgery is, removal of cancer, tumors, and then plastic surgery is more cosmetic closure. So we go in and remove the lump, at the same time, do some rearrangement to put the tissue back together. So when the area is closed, it looks like a natural breast, as natural as we can make it. So that's what oncoplastic surgery is. It's commonly done in France. That's where it kind of started.
Okay.
The surgeons over there, they do the whole plastic surgery after oncologic surgery. Here, we work with plastic surgeons. So if a patient has a mastectomy, then we work with a plastic surgeon to get reconstruction. But that can also be done at the same time. So what I do is when a patient is having a lumpectomy, which is, taking out a small tumor, we're preserving the breast, but putting it back together so that it looks as natural and symmetric to the other breast.
Okay.
So that's what I do.
How does it differ from more traditional breast cancer surgeries that many people might be familiar with? Normally, women need a mastectomy and then need to heal for a period of time.
So, things change over time. And when I was training, when we were taking out lumps, we didn't necessarily rearrange tissue. We just closed. And so after healing, after radiation, sometimes the tissue can kind of fall back. So can have a deformity in the breast, the way that it looks compared to the other side. They didn't really have a good way to fix that. So over time, there's been advances. We've had devices that we've placed in there to kind of cover that area. But tissue rearrangement, which, using your own tissue gives you the best results. So that's something that we do. The other type of surgery, mastectomy, where we're removing the whole breast, in the past, when someone is diagnosed with cancer and they have advanced disease, they didn't really have a lot of options except to remove the whole breast. And sometimes women would not get any reconstruction, so they would have a flat result. Or if they're working with a plastic surgeon, typically they may have reconstruction at a later time with an implant or a flap. So what we can do now, because of advances in treatment, we're able to treat the cancer before surgery in some cases, which is called neoadjuvant therapy, with chemotherapy, sometimes with endocrine therapy, immunotherapy, and then we're able to shrink the cancer and then do their surgery, where the surgery could be a lumpectomy at that point. Or if we do a mastectomy, sometimes we're able to do a nipple-sparing mastectomy, which basically saves the skin and the nipple and has a superior cosmetic outcome. We're doing a nipple-sparing mastectomy. Typically, I would work with a plastic surgeon. They can put in a tissue expander at that time or an implant, or if they want to have their own tissue, they can do a deep flap later on, basically taking fat from their belly and moving it up to where the breast tissue was, so it feels more natural. So those are kind of the things that over time has improved. So oncologic outcome is improved, but also the cosmetic outcome is improved.
Absolutely. It sounds like it. Okay. So what inspired you personally to pursue this specialty?
Yeah, I've always loved working with women.
Okay.
So when I was in medical school, I was part of this team where there was a tumor board and a multidisciplinary clinic, and I loved what they were doing there. So there was a breast surgeon, an oncologist, a radiation oncologist, the plastic surgeons, and we were all seeing those patients together. And I saw that even after surgery, they follow them for a long time, making sure that they're doing well as far as survivorship. So it was really like a community. And I loved taking care of women and the camaraderie that comes with it. Personally, my aunt actually was diagnosed with breast cancer. So she had this lump.
Okay.
She lives in Sri Lanka. I'm from Sri Lanka. I went to visit. I think I was in medical school at the time. And she didn't tell anyone about it. She wasn't doing anything about it. And just so I happened to be there, she told me. And her worry was that who's going to take care of my son and my husband if I have to go through this. So she was in denial, basically. She was worried that, she'd have to leave them to get treatment, or, those were the things that she was thinking about. And I was like, well, if you don't take care of it, then you're not going to be around for a long time for them. So there's a lot of misconceptions about breast cancer. Can it be treated? Is this the end? That sort of thing in general with cancer. But breast cancer, found early, treated, is curable. And people live a long time afterwards, and they die from natural causes, other causes like heart disease. So breast cancer is very common. 1 in 8 women are diagnosed with breast cancer, but with early detection, getting mammograms on time, when you're supposed to, can really find those small lesions, and the treatment is a lot less. And the outcomes are great, more than 95% survival for stage 1 disease, stage 0 disease. So most of the breast cancers that are found are stage 0 when they're ductal carcinoma in situ. But particularly here on the island, there is more patients diagnosed a little bit later. So it's really important to bring awareness to that and getting mammograms.
Get the screenings done, exactly, so we can catch things early. Absolutely. When a patient is diagnosed with breast cancer, what are the first steps in determining if oncoplastic surgery is an option for them?
So that's a pretty complex question.
I'm sure.
So you're going to get a complex answer. So we have to look at everything,
Okay.
right? So we are going to look at their past medical history. We're going to
Okay.
look at their family history. If they had family history of breast cancer, we do genetic testing for them.
Mm-hmm.
If they have a BRCA gene or a high risk gene, we're going to recommend removing the breast completely and then doing reconstruction. If they have a very small lesion and they have no family history, they don't have a genetic mutation, they have no involvement of their lymph nodes. If they do, then we kind of go the route of getting neoadjuvant therapy with an oncologist. So that could be chemotherapy, immunotherapy, as I mentioned earlier. So it depends on, what they present with.
Mm-hmm.
But if it's a small lesion, no distant disease, no axillary involvement. We look at biomarkers, estrogen, progesterone, HER2. As long as they also have enough tissue in their breast, if they have smaller breast size and disease that's relatively large for them, breast preservation could be difficult. But if it's a small lesion and they have enough breast tissue, we can certainly do oncoplastic surgery. So we use a localization device because when those lesions are small, I wouldn't be able to feel them.
Yeah.
So we also want to get the right area because sometimes you can have fibrocystic disease, lumps and bumps, but not necessarily where the cancer is. So we mark where the cancer is, we go in and remove that lesion, do some tissue rearrangement to put everything back together. Depending on the disease, we check lymph nodes, and then that helps the oncologist stage the patient to see what additional treatment they might need afterwards.
Okay.
But we always want to offer the option of oncoplastic surgery and breast preservation if possible. But in some cases, we have to take the disease into account.
Of course.
What treatment they're going to have.
So as of now, when a full mastectomy is needed, it's never possible to do reconstruction right away in the same surgery.
That's not necessarily, there's caveats to that.
Okay.
So let's say you have a larger size lesion, your breast is not so large, close to the skin or close to the nipple. You can't really have a nipple sparing mastectomy. We can do a skin sparing mastectomy, work with a plastic surgeon at the same time. They can come in and put in a tissue expander. Later on, they can remove that and put in a permanent implant, or they can do a flap. So the surgeries are staged most of the time, but they're still, the reconstruction process is starting the same time the oncologic surgery is happening. So you don't have a flat outcome at that time, but it's not the final outcome. In some patients, the disease is so small that we're comfortable doing the permanent surgery right away. So it'll be a conversation between myself, the patient, and the plastic surgeon to see, what's the best route for this person. And in some cases, I take out the tissue, they're able to put the permanent implant in at the same time or even do a flap at the same time. So it can be done at the same time, but we look at the disease. If they need to have additional treatment after the surgery, like radiation, sometimes we prefer to do all of the treatment first and do the reconstruction later. Because it can, if you have to have radiation on top of a flap, that can make things complicated for healing. So we take all that into account.
Okay. How do you collaborate, with radiologists and oncologists at RUMC to ensure, that a patient gets a seamless plan of care?
Yeah, that's kind of the main thing that I do as a breast surgeon.
Okay.
We're always in touch with the radiologist because that's where, a lot of the patients come from. They get a screening mammogram, they have an abnormality, they have a biopsy, and if they're found to have cancer, then we have navigators at RUMC that help those patients come to me and see me and get started with, what would be the next steps for them. So I would talk them through, what the diagnosis is, what's their biomarkers, What does everything look like on imaging? And, what are the possibilities? Can we do a lumpectomy? Do they need to have a mastectomy? Do they need to have treatment before so we can shrink the cancer and give them more options as far as surgery? So we're talking about all of those things when they come for their first appointment.
Okay.
So we really have a plan of care from the first appointment. And then, if they go for surgery first, then they would come to the hospital, we'll do the surgery. Most of the surgeries are outpatient. If we work with a plastic surgeon, we'll work together. And when they're done with their surgery, they've healed from their surgery, then we would go to the next step. That could be radiation treatment. So I work very closely with the oncologist as well. And we have a tumor board, multidisciplinary tumor board, where we discuss, what's the best treatment course for each patient. And typically we do that prospectively. So even before they have surgery, we discuss, what are the possibilities for this patient and what's our plan. And then when they're done with their surgery, they would go to the oncologist, the medical oncologist, or the radiation oncologist. We do genomic testing for some patients. So if they have estrogen, progesterone positive, HER2 negative disease, these are biomarkers. We look to see, we take the tumor that I've removed, we send it for a test to see what is the chance of recurrence. Is this an aggressive type of cancer or is it not so aggressive? And if it's an aggressive type of cancer, that tells the oncologist that they may need chemotherapy. If it's not so aggressive, they can use endocrine therapy, which is a pill, is better tolerated. So we really tailor the treatment for each patient based on their tumor. And then we also look at radiation. Is it necessary to have radiation? And then they're referred to the radiation oncologist. And radiation treatments can be about 3 to 6 weeks.
Okay.
And yeah, so there's, there is a lot to be done, but typically there's a plan. We go back and forth, talk to each other. If a plan needs to be changed, we talk to each other and move through it accordingly. Even if someone is getting neoadjuvant treatment, I do follow them during that period because I want to see, is the treatment working? Is their cancer shrinking? And is this going to change my management as far as what type of surgery they're going to have? And I would probably ask for some additional imaging to see how it's progressing. So definitely, following that patient throughout.
Let's talk a little bit about genetics again. Let's go back to things like the BRCA gene mutations or family history. How do they affect the patient's chances of developing breast cancer? And, does that change the surgical approach?
Right. So someone who has a BRCA mutation and they've been diagnosed with breast cancer, they have another 30% chance or so of developing another cancer in that breast or the other breast. So what we do is we recommend a mastectomy because we consider that a high chance of getting another cancer. So this patient might be better off removing all of that breast tissue. But we do see some patients who have family history, high risk. We do their testing and they test positive. In some patients, they want to go ahead right away and get their surgery, remove that breast tissue. But I have had some patients who were older or had some other medical concerns and didn't really want to go through surgery and would rather follow. So, if they're older, like, what are my chances? And they want to get imaging done and follow with a surgeon every 6 months or so. So it's a lot of follow-up. It's a lot of imaging. So you have to really commit to that. But I have had patients who've had BRCA mutations who didn't want to have surgery, but we follow them. We make sure that, if they are developing something, that we catch it early and they have surgery. But I advise them that, the treatment that you're going to have when you don't have cancer versus the treatment that you're going to have with cancer is going to be different, right? There's going to be a lot more treatment with the cancer. It's not just the BRCA mutations. There are many other mutations that we look at. There's a panel of mutations that we test. Typically, we do that, when I see them for high risk or if they're newly diagnosed with breast cancer, we send that test to see what kind of surgery would be best and what their goals are also. If they are tested positive, We also recommend that their family members get tested. So we refer them to a genetic counselor. I do some counseling myself, and their family members can get tested.
Are patients more susceptible if they have a family history on either the maternal or the paternal side? Are
Oh,
you?
it doesn't matter.
It doesn't matter.
50-50.
50-50.
Yeah.
Okay. And I know Staten Island has some of the highest breast cancer rates in the city. What do you think attributes to that?
So, yeah, when I came back, I've been hearing about this
Yeah.
and I wasn't aware of it before. And, we were talking about that. And the thought was that it could be there's a lot more people that smoke. Maybe there's more people who have higher BMI. That could be a possibility. We did have the garbage dump
Mm-hmm.
here years ago.
Yep.
So that could be one of those things. So, could be related to all types of pollution. And also it could be that screening is not done early, that we're catching things a little bit later.
Okay. Some women believe that breast cancer surgery always leaves them disfigured. How do you address that and comfort
Yeah.
them?
Yeah. So if you Google, lumpectomy pictures or mastectomy pictures, there are some pictures that can be a little bit scary to look at. So typically I tell them, don't look at that. Look at pictures from the plastic surgeon if they're getting reconstruction to see what their outcomes look like.
Hmm.
With the lumpectomy, we always try to rearrange the tissue where it looks as symmetric as possible. And if it doesn't, I always give them the option, later on, you can get some fat grafting where that area can fill up.
Fill it
But
up. Okay.
most of my patients, I haven't had anyone who wanted to go back and have something done. For that to happen, they really have to have a lot of disease, or they've had to have multiple surgeries for a re-excision for a positive margin. But I definitely try to take the temperature of the patient to see what their goals are.
Hmm.
And some patients are like, just take a large chunk of tissue that you need, but I don't want to have a mastectomy because I don't want to have to deal with the longer recovery or whatever that may be. And they're okay with a little bit of a defect. So really, like, I look at what the patient wants, and what their goals are as far as recovery, the cosmesis. Because sometimes, I've had patients where they've had a beautiful outcome, but it's not exactly what they had in mind. So
Yeah.
we also have to kind of show them what it could be and what their goals are.
A bit of reassurance, right?
Right.
Okay. What other misconceptions do you come across with patients when it comes to breast surgery that you would like to maybe debunk some myths or?
It's so common that when someone's diagnosed, they know someone that's already been diagnosed, and
Mhm.
and when they come to see me, we certainly talk about what everything is and what we do and what the plan is. So I think they're pretty aware of what's to come. Um, it is We do a lot more outpatient surgeries, so I think some of the older patients are like, "Oh no, I didn't realize I was gonna go home."
Yeah.
So that could be one of those things. And as far as what you mentioned, getting reconstruction at the same time, yes, it's definitely possible. We try to work towards that, but we have to take each patient into account and what their disease process.
Do you ever, run into any cultural or maybe generational differences in how women approach the idea of, reconstruction and aesthetics?
Yeah, absolutely. So, when I was training in Florida, a lot of the women there, they were more interested in lumpectomy and breast preservation. But when I was working in Houston, a lot of the women diagnosed with cancer were a lot younger, and they preferred to have a mastectomy and not kind of look back. It really depends on the area. It depends on, like you said, cultural differences. It could be
Mhm.
try to work with each patient to see what their goals are and what makes them comfortable. Having prophylactic bilateral mastectomy is not necessary for a lot of patients. But there are some patients who say, I'm so anxious, like I don't want to think about it. And we try to reassure them because the risk of a new cancer on the other side is not so high if there is no genetic mutation. If there
Okay.
is, then certainly then we would recommend the mastectomy. But if there's no genetic mutation, the chances of a new cancer on the other side is quite low. So it's not necessary. We have to kind of talk through all those.
And you mentioned that France kind of spearheaded this whole oncoplastic surgery. How long has it been around for?
It was around when I was training. So I don't know, 20 years or
Okay.
so.
And how about here in the U.S.? It's been around for that long as well?
Yeah, it's been around, but maybe not picked up as much everywhere. Not so many people trained in oncoplastic surgery, but that's changing.
Okay.
Yeah.
And you mentioned that most of these oncoplastic surgeries are outpatient, right?
Yes.
So what does the recovery process look like?
So usually I tell my patients recovery could be a week or two,
Okay.
depending on, how big their lesion is, how much tissue we had to rearrange, how much tissue we have to remove. It could be pretty seamless. I have a lot of patients tell me, I had no pain, Dr. Yoga. I didn't have to take any medicine.
Wow. That's wonderful.
So I'm like, great, that's the goal.
That's the best outcome you could ask for.
Yeah. I wasn't expecting it because, I expect everyone to have a little bit of pain and we give them pain medication for that.
Okay.
But sometimes they really have nothing. And that's great. I'm happy when they tell me that. We typically say at least 2 weeks. You want to take it easy.
Take it easy.
You don't want to do anything rigorous. Don't walk the dog that's going to pull you or let the grandchildren jump on you or, things like that. No swimming, no tub bathing in water and immersing yourself in water for 2 weeks. Besides that, I tell them, you can eat whatever you want, move around. You don't want to be sedentary.
Yeah.
But take it easy during that time. Don't be cleaning the cabinets and vacuuming the floor. We have to particularly say that. Some of
Don't
our
jump
patients.
right back into it.
Right, exactly.
And
So
then,
ask for some help and take it easy for a couple of weeks.
and then they just come back in for a follow-up appointment.
Right.
To
Yeah.
check
So
the
I see
healing.
them post-op about 2 weeks or so later, and we'll evaluate the area, make sure everything's doing okay. If pathology's back, we'll discuss the pathology at that time and talk about next steps.
Okay.
If it's a mastectomy, recovery could be a little bit longer. I
Yeah.
usually say about 3 to 6 weeks. They'll also follow up with a plastic surgeon if they're getting reconstruction. With a mastectomy, there's typically drains.
Yes.
So they collect the fluid that our body makes. Our body's always making fluid. Even with the lumpectomy, there's fluid, but it gets reabsorbed back into the body. With a mastectomy, and we want to remove all that fluid because if there's a foreign body in there, it can increase the chance of infection. So they have these drains that collect the fluid that have to be emptied and measured, and they bring the measurements back to the post-op appointments, and depending on what's coming out, as the output goes down, the drains are removed, and then they continue to follow up with the plastic surgeon for completion of the reconstruction.
That takes a couple of months of healing, though, right? Usually, or
Right. It depends on what they had, what their cancer is, and what type of treatment we're planning. If they have to have radiation, sometimes the plastic surgeon will wait 6 months to put in the permanent implant or do a flap.
okay.
But if there's no radiation, then typically, over a couple of months, they are able to finish up the reconstruction process. If a woman's had their nipple removed and had a skin-sparing mastectomy, they can have the nipples tattooed. So 3D tattoos that are available. So there's a few steps, but they'll keep following up with the plastic surgeon for the reconstruction and completion of the reconstruction.
Well, thank you. This was very informative. I feel like we learned a lot in this episode, and I would like, to thank you for helping us understand, these advancements in breast cancer surgery. And, oncoplastic surgery truly represents hope, and not just for survival, but, for maintaining confidence and quality of life, which I think is so important. And as we recognize Breast Cancer Awareness Month, we encourage everyone listening to schedule their mammograms, learn their options, and take charge of their health. So if you would like more information about breast health services at Richmond University Medical Center, including consultations with Dr. Yoga, please call 718-818-1161 or visit rumcsi.org. You've been listening to RUMC Connections. I'm your host, Meredith Gaskins, and we'll be back soon with more conversations to keep our community informed and connected.